vision goes away.
Thank you, sir. So
Yeah.
I think we have next Dr. Anagha, and she'll be talking on when my patient demands spectacle-independent lifestyle.
Very good morning to all of you. Thank you so much, Dr. Sonu. So basically, we'll be speaking on how the trifocal family of geometric helps us to achieve spectacle independence. So basically, in today's fast-moving world, where patients' expectations are reaching sky high, we don't need just the distance clarity, but also important is the intermediate vision as well as very, very good near vision. And all of us, to a certain extent, fear multifocal IOLs for the fear of having dissatisfied patients who will keep complaining and keep coming back to us with waxy vision or glare and halos. Yes, of course, the increased cost and the fear of having to do an IOL exchange. And as times keep changing, and so are patients' profiles, who are being now more educated and demanding, it becomes more of a challenge to select not only the right patient, the right lens, do a good counseling, and definitely do a precise biometry and surgery so as to give the patient a perfect visual outcome. So in our center, we make it a point to have a repeat reading for all our premium patients, be it torics or multifocals. Definitely ensure that the patient is not dilated or you don't do an applanation before that so as to have a pristine cornea. We also include an OCT macula to rule out any very mild changes in the macula similar to an ERM or a lamellar macular hole, which could impact a clinical visual outcome. A good ocular surface assessment, ensure that the ocular surface is good. If not, then you may need to treat it pre-op. Topography in cases of astigmatism so as to rule out irregular astigmatism, which can cause higher aberrations and can impact the quality of vision when you're using a toric multifocal, a pupillometry and an angle alpha so as to have a minimum of glare and halos. In case of astigmatism, we just put in the K1, K2 onto the Barrett toric calculator and see whether the patient needs a toric, and the patient is advised accordingly. We don't have a specific threshold of a 1 diopter or a 0.75 diopter, and probably that is why the low power torics are also, the numbers are increasing. But we are giving good vision to the patients. So we also discuss the options of toric multifocals and the other options that we have to the patients depending on their affordability. We all know that, yes, an ideal multifocal IOL is very elusive, similar to an ideal wife or an ideal husband. And selecting the best multifocal IOL for your patient sometimes can be challenging. So when you're doing a talk with your patient, you need to give them good chair time pre-op so as to have less chair time post-op. Speak to the patient regarding their lifestyle choices, their work activities, what distance they usually read, and what are their visual expectations, whether they have understood what they are in for. Explain to them the principles of the various options that they have, and remember that a trifocal is basically a combination of two kinetiform profiles, and you have these steps which give you good vision at different distances but would also have loss of light, as we discussed in the previous session. So when your patient wants spectacle independence, and what we do at our center is ask them 3 questions. The first is, how much of night driving do they do? Whether it's regularly, whether it's sometimes or never. A patient who regularly does, maybe daily, say Bombay-Pune night driving, you would avoid using a trifocal. You'd think of using an ADOF or best probably an advanced monofocal. Sometimes you counsel them about the glare and halos and whether it would be acceptable to them. If they never do, then definitely you can give them the choice of trifocal IOL. If the night driving is more important to them than the spectacle independence, again, it's better to avoid a trifocal. If the patient has understood and accepted that he might have a glare and halos and he would still want to opt for spectacle independence, the second most important question is how much of intermediate vision he requires, whether it's computer work or any other kind of intermediate vision. So then it becomes important for us to address that intermediate vision, whether it's trifocal or an ADOF with a micromonovision. And if the patient sometimes only requires an intermediate vision, still trifocal and ADOF would be the best choice. There are still patients who would use reading distance and things at near, which is of more importance to them. For them, having crisp near vision or crisp vision at near becomes more important to them. So you need to also, in such patients, decide the near addition. So when you are having near vision, you have patients reading, say, for at this distance versus at this distance. You need to see what add your multifocal or trifocal is giving you. So what we do is we just give them a reading card in the preoperative workup and see at what distance they are more comfortable, and accordingly you advise what lens they would basically suit them. In any case, do not promise 100% spectacle independence, and always say that a small number of patients might require fine focusing for distance as well as definitely for near. So if your patient selection and expectation setting is meticulous, trifocals are definitely performing better in all these distances. And this was an interesting article which compared 5 presbyopia correcting IOLs. This has an optical bench assessment. So this was what it showed, is basically all these lenses which are now available have a near light distribution of, say, around 25%, 21%, or around 28 to 36% depending on the pupillary size. So what's new today? So what we need today, as we said earlier, was if a patient expects a better near vision or crisp near vision, we need to emphasize on that. Plus, if you have an added advantage of a preloaded technology, minimum or no rotation because of a better optics and a better stability with minimum of PCO, today we have with us the Vivanex geometric trifocal family, which gives us spherical aberration correction, which is more tolerant to coma, especially important in patients where there could be a slight decentration, a good material which is glistening free and no calcification, a design which we have used for the last so many years with the Vivanex technology, and definitely a preloaded advantage where it consistently delivers a very smooth intraocular implantation, be it a 10 diopter or a 30 diopter lens with equal elan. So this has an intermediate ad of 1.75 and a near ad of 3.5 diopters. There are two in this family, the Vivanex Geometric and the Vivanex Geometric Plus. The central truncated diffractive optics of 3.2 millimeter zone. So if you look at the difference between the two, I would not go into the video's details, which was described already yesterday. So this was the first day post-op. You have a beautiful central zone which is perfectly centered on the pupil. Important to note is the Vivanex Geometric gives you a very good vision for distance, and the Vivanex Geometric Plus gives you very good vision for near. And both of them have the central hump in the intermediate zone. So if you have a patient where there is a full range of good vision in good light, so if you see the pupillary size in the 3 millimeter zone, you have a very good Vivanex Geometric Plus giving good near vision, whereas in the slightly dilated pupils, you will have a very good vision for near also. So this is, again, you can see the arrow pointing to the very good vision for the Geometric Plus, even in poor light. Important to note is the loss of light is just around 9.9%. And for near, with the Geometric Plus, the near distribution, as we saw in the earlier slides, the maximum was around 21 to 25. Here it's 38.6%. So that gives us the extra edge for clarity of vision for near. So the patient's complaints about having to depend on glasses for near is usually very, very less. So this is an important defocus curve. So if you look at the bold black line, which compares, which basically uses a geometric in one eye with the paired approach in the Geometric Plus in the other eye, it gives you excellent vision for distance and an excellent vision for near, compared to an approach where you have Geometric in both eyes or Geometric Plus in both eyes. So this is our experience. Till date, we have finished, actually till date, 125, yeah, we're just completing, 125 implants. and sharing today 70 eyes implant data of more than 3 months post-op. So there were most of them having better or more than 6/9, 6/6 for distance, intermediate as well as for near. And if you see the defocus curves for all the 3 categories of geometric plus or geometric in both eyes, as well as the geometric toric and geometric plus toric in both eyes, the defocus curves are similar. So you can use either in both eyes. So you can use geometric in the first eye and geometric plus in the second eye, or other way around. The spectacle usage was minimal post-op. The photic phenomenon were minimal, and patient satisfaction was very good. The reading speed was very good, especially with the geometric plus, even in poor light. So it basically showed that the vision for distance, intermediate and near was very high. That in toric platforms, the stability was very good. And finally, to conclude, it gave us very good visual outcomes, satisfied patients, spectacle freedom, minimum of dysphotopsia, ease of implantation with the preloaded technology, boosted our confidence, and our counseling, which was important, where the patient's consent also was specially taken for having realistic expectations. All in all, will give us very good visual outcomes and happier patients. Thank you so much for your kind attention.
Just one question. Do you really think the pairing is needed with geometric and geometric plus in your practice? What have you seen?
So we have used earlier geometric also in both the eyes. When you have done geometric in one eye, the patient is happy with the near vision. But when we know scientifically that the geometric plus will give us even better for the near, there is no harm in using the geometric plus in the other eye and giving the patient that extra advantage. There are patients who will, for example, those patients who are not doing much of going out and who are using only things at near, we would in fact put in geometric plus in both the eyes in rare situations.
I think the speciality about this lens is that this is the only lens which plays around with the light distribution, keeping the power same in for both the types of lenses. As Sajay asked, I also put a geometric as my go-to lens in the first eye. The patient is perfectly happy, quite comfortable. His or her visual demands are such that they are quite. I go ahead and put the geometric in the second eye also. It's just like putting a low ad multifocal and then you put a higher ad in the second eye. But in case the patient says my near vision is less than optimal, then we go ahead and put a geometric.
So in that case, does the patient read N8 or his clarity at N6 is less?
To me, more than N8, N6 is the visual satisfaction of the patient, which is important.
So, but that could also be because there is still a cataract in the other eye yet to be operated, and patient might need some time to adjust.
No, intuitively the combination would work well, but if you put the first this eye, and if it is patient is absolutely happy, then sometimes repeating the same lens also works quite well, at least in my hands. And I would say that, nowadays, rather than discussing about multifocal lens as to me, multifocal lens is the go-to lens if the patient can afford it. And then you exclude patients who cannot have it. And I think most of our practices are wearing
Yes,
around
definitely, sir.
So I think thanks, Anagha, for that wonderful